Good Samaritan Regional Medical Center owns about 84 acres of land to the north of the main building. It's considering expanding its hospital onto this land to build new medical facilities and install on-site housing for specialists. That parcel of land that looks strangely like Minnesota, actually, just to the north um, west, is the land in question here. This cost-benefit analysis will monetize the costs and benefits of this project to determine the net present value, and it will ultimately make a final policy recommendation. So the stakeholders in this CBA are the Good Samaritan Board of Directors, because they are the ones who are concerned with the profit motives of its hospital, its employees, its patients, and the Corvallis residents, who will have to live near and look at this new expansion and be served by it and be treated by its facility. Impact categories are mainly construction costs. So, excuse me, construction costs of building the main facilities as well as the housing. The land was purchased in a $1.7 million purchase. It was formerly Owen's Farm until the purchase was made in 2002 for $1.7 million. That will be considered a cost in the CBA. That may be a controversial decision. I go into that in my paper because the land was already purchased 2002 before they even announced this plan. However, they stated their intention, and the main motivator behind the land purchase was in the future to develop it and expand the hospital. So that's why I'm including it as a cost in this CBA. Another cost will be nuisance from the construction site. People who live near the future facilities and the housing will no doubt be affected by the noise and the dust being thrown into the air. They might have to cancel neighborhood barbecues, what have you. So that will no doubt be a cost. Benefits from this project include revenue, because Good Samaritan will now be able to treat more patients, and so that will bring in more revenue from the hospital. Time value saved from specialists living on site. I was kind of excited because this was a pretty specific excerpt from our book, but I was able to apply it in the CBA, and it is non-negligible. It's having specialists live on site and not have to commute to work definitely is a benefit in this CBA. Um, Good Samaritan is funded largely by donations, and so it's not a large leap to assume that they will experience more donations when this project gets underway. Convenient access to quality healthcare. Um, with the new facilities, they're opening like mental health services. I believe there's some more oncology equipment and services being offered. So patients who formerly had to maybe commute to Portland or to Salem to get this health care no longer to. They'll be able to stay in Corvallis, and that's a convenience, is a benefit, in just being able to go right across the street to get their health care. Wages, I added that into my paper, but that's both a cost and a benefit for my stakeholders. It would be because including the new facilities would hire more doctors and workers. That would be a benefit to them. However, it would be a cost to the Good Samaritan Board of Directors because they're the ones paying it. So because it would be a no net effect, I did not include it, but I thought it was worth mentioning. Lifetime of the project will be 84 years. I arrived at this figure because the previous Corvallis General Hospital, which used to be at 27th and Harrison, lasted 42 years until they moved to their Good Samaritan's current location. And so my assumption was that with new building materials and because this is a large investment, there's higher incentive to stay put. the new hospital as well as the on-site housing will last 84 years, which is double 42. Monetizing the costs of this CBA started with the construction of the housing. I used a tool called constructioncost.net, which is a series of fields that you input your assumptions into. For example, I assumed that the square footage of each house would be about 2,100 square feet, which is the mean square footage of the median square footage of a U.S. house in 2010. I included things like 150-foot square garage, a driveway, balcony, attic, and I specified that it would use Class 4 building materials, which is good standard. And I arrived at a figure which I multiplied by 10, but I also subtracted fixed costs such as permitting, engineering, design, because that shouldn't rise with the number of houses being built. I assumed 10 houses would be built to house all the specialists. Ultimately, for the housing complex, I arrived at a figure of 2,378,644. For the construction of hospitals, I relied on a survey by Health Facilities Management, that found that in 2016, the average cost per square foot of building an additional hospital was $4,000 per square foot. Excuse me, $400 per square foot. And I assumed that the facilities would be $80,000 square feet. Multiply that, you get $320 million, which I think is a reasonable figure. And again, the land purchase was $1.7 million. That's included in the cost here. Monetization of benefits. So looking at the value of travel time saved from our book, which involves taking the salary of each worker, multiplying it by the travel time saved, we get $176,106.67 saved per year. That's assuming that I relied on a study by the U.S. Census. The average U.S. commute time was 25 minutes, and that the average doctor, physician, surgeon makes $209,000 a year. And that's how we got that figure. I used the Waters method of multiplying the wage times travel time saved. For additional revenue to the hospital, I relied on a study by the American Hospital Association that found that the average revenue for a hospital for each inpatient bed was $80,464 per year. I then had to heavily extrapolate from this figure. So I found a figure by the U.S. Census that 7.6% of Americans were admitted to an overnight stay in the hospital in 2014. So using that figure, applying it to the Corvallis population of about 51,000, I would assume that the new facilities would see 4,139 patients per year. Multiply that by that 80,464 figure. You get 333,044,635. That seems like a lot, but remember, this is America. Healthcare costs are pretty high. Discount rate was set at 2.7% for the CBA. I used this from our book. This was a figure derived from the U.S. borrowing rate. In the sensitivity analysis, I will look at adjusting it to 1.7% or 3.7%. Calculating the present value, I use the typical formula. I'm not going to rattle off all those figures. They're right in front of you, but as you see, the net present value is positive and very substantial. If we adjust the sensitivity analysis, if we adjust the discount rate, you can see that no matter what we set it at within our bounds, this sensitivity, the net present value is still in the billions, positive, very substantial. This leads to an obvious policy recommendation. The expansion will need to be approved by voters in November of 2017, and a CBA such as this will provide them enough information that this project should be approved. So I'd just like to take a few moments, I know I'm a little bit over my time here, to discuss my methods, obstacles I faced. So something to talk about in my paper is a lot of the costs and benefits, the impact categories that I list were very difficult, if not possible, to monetize without contingent valuation. How do you monetize the nuisance of a construction site without asking people what would you be willing to pay to avoid a construction site near your home? How do you monetize the possibility of clear cutting a forest to make way for the new facilities or the housing? Um, it was just outside the scope of this CBA. With more resources, a more accurate figure would have been arrived at. Another thing was that the distribution of benefits are slanted heavily towards Good Samaritan board of directors. That is again just the nature of this. Their costs and benefits were much easier to monetize and discount. So thank you for watching. I hope you enjoyed this cost benefit analysis on the Good Samaritan Regional Medical Center expansion plan.